bacterial infection. These are the gross mechanism of the antibiotic resistance. These are actually the genetic mechanism. There are some chromosomal, extrachromosomal. You all know about this, and we know how it can be spreads from human to human, animal to human, environment to human, poultry or fisheries to human. And there's a vicious cycle of this antibiotic resistance. Actually, the discussion of this certificate course is to combat the antibiotic resistance. So this slide is in front of you to recap the different way of the antibiotic resistance spread. We know during culture sensitivity report, we have gotten some special variety of resistance pattern, like methicillin resistant, Staph aureus, extended spectrum, beta-lactamase producing some bacteria. So just it is a recap from the CLSI guideline 2023 by Dick's division, broad micro dilution and different methods. And ultimately, these are the interpretation how we can interpret the MRSA. And this is also MRSA. This figure showing the MRSA, we can see that the cefoxitin sensitive isolates. So these are the cefoxitin sensitive isolates. There are some vancomycin sensitive intermediate. Actually, this figure it needs some correction. And actually, this presentation was given a few weeks ago, and recently I have gone through the CDC guideline. I've said that the vancomycin resistant Staph aureus, it is okay 16 microgram per ml or more, and the sensitive vancomycin sensitive Staph aureus defined as MIC 2 microgram per ml less than or equal. In Visa, it is 4 to 8 microgram per ml. And what about AIDS Visa? Actually, AIDS Visa means heteroresistant Visa. That means phenotypically they are sensitive. Their MIC, most of the population MIC less than 2, but some of the population having the MIC 4 to 8. So this is the AIDS Visa lies between the sensitive and intermediately sensitive Staph aureus. Now, this CLSI guideline on the ESBL producing bacterial identification, and we can see the cefotaxime alone and combination with clavulanic acid, ceftazidime alone and combination with clavulanic acid, and the zone diameter in the combined disc, it is more than 5 or equal to the 5 millimeter, then the zone diameter of the disc alone, that is the ESBL producing bacteria. So actually why I am showing this type of detection of MRSA, ESBL, some bacteria resistance pattern, actually just it is a recap so that during discussion of the empirical therapy, we can correlate more easily. So as stated earlier in my presentation, the empirical therapy, actually empirical therapy, the clinician judge by their experiences, observations. Of course, the local antibiogram always helps them for this clinically educated guys. So we all working in the laboratory should produce at least annual antibiogram, local antibiogram, so that empirical therapy will be more beneficial to the clinician, patients, and also our microbiologist. And the most of the PowerPoint presentation on this empirical therapy, actually it was made from the Antibiotic Essentials, a book. It was edited by Cheston B. et al. And published Elsevier in 2019. And most of the slides are provided by our honorable teacher, great teacher, Professor Akram sir. I'm grateful to him. And besides this presentation, PowerPoint slides, I have modified some slides and added some slides by taking some empirical therapy from clinical book, Davidson Principles and Practice of Medicine, and also from some information from CLSI Guideline 2023. So now I am going to present the empirical therapy according to the bacteria, not according to the any disease, because as we are microbiologists, it is very easy to us if we correlate this empirical therapy on the basis of the microorganism. So at first, gram-positive bacteria, Staphylococcus aureus. We know the Staphylococcus aureus may methicillin sensitive or it may methicillin resistant. So actually, there are lots of things mentioned here. The main thing is that actually Staphylococcus aureus in some site it is colonizer, in some sites it is pathogen. So we must be careful where they will be colonizer, where they will be pathogenic, and of course there are some immunocompromised or immunocompetent state, other factors, age, the community setting, hospital setting, all should be considered during the empirical therapy for Staphylococcus aureus. Either it may be methicillin sensitive or resistant. In that case, if we consider the hospital-acquired methicillin-resistant Staphylococcus aureus, the ceftaroline, daptomycin, linezolides, these are the preferred therapy. And the community-acquired MRSA, minocycline, doxycycline, these are the preferred therapy. And VISA or VRSA, just briefly mentioned earlier in the presentation, linezolide, daptomycin, these are the preferred therapy. But we must remember that actually these are the suggestions. Actual empirical therapy should be guided by our local antibiogram. During blood culture, this slide will be frequently comes to you. During blood culture, if it is positive out of 4, say 4 blood culture done, only 1 positive. In that case, usually it is low grade blood culture positivity. It indicates skin contamination. If the growth in the 3 out of 4 or 4 out of 4, usually it indicates intravascular infection, osteomyelitis, abscess, like this. So the blood culture number and size is very important. Next bacteria, Staphylococcus epidermidis, Staphylococcus lugdunensis. So here again, some sites are colonizer, in some sites they are pathogens. Again, immunocompromised or immunocompetent, other factors should be considered. And the methicillin sensitive, in that case, naphthalene, oxacillin, it is okay. And methicillin resistance, Staphylococcus epidermidis, again, linezolide, daptomycin, vancomycin, these drugs are preferred drugs. We know the Staphylococcus lugdunensis is a coagulase negative Staphylococcus, but often misidentified as Staph aureus due to clumping factor. But it is pain sensitive to antibiotics. Staphylococcus saprophyticus. Usually, these organisms are non-pathogenic except urine. and they causes the honeymoon cystitis. You know, the this Staphylococcus aureus saprophyticus, the preferred therapy is amoxicillin, cotrimoxazole, nitrofurantoin, and we can choose any type of quinolones. But always remember, actually these are the suggestions, and this choice always guided by the local antibigram. Now, Streptococcus pyogenes, they are mostly skin contaminant if we get from CSF, but they are pathogenic when we get from blood. Sometimes from throat in wound swab, as well as sputum. So during diagnosis, we should be careful whether it is pathogenic, contaminant, colonizer, and what are the immunostatus. So these are the preferred therapy. Actually, it is the proposed preferred therapy. Amoxicillin in beta lactams, you all know. Streptococcus agalactiae, and if you get the agalactiae in the CSF, it is pathogenic. Also from blood and throat. But in throat, usually it is the colonizer, but it may be the pathogenic. So there are some condition, the factors during the diagnosis, we should consider those factors. And the proposed preferred therapy, ceftriaxone, penicillin in case of meningitis, ceftriaxone, penicillin in case of bacterial endocarditis. There are some other alternative drugs, but we should remember that aminoglycosides and tetracycline are ineffective. Breeders Streptococcus group, mostly they are non-pathogenic, but they can be pathogenic if they are accidentally enter into the blood and causes bacterial endocarditis. The preferred therapy is ceftriaxone and any first generation, second or third generation cephalosporin. Alternatively, amoxicillin, meropenem, and vancomycin can be used. Again, the 1 out of 4 culture positivity usually indicates contamination during venipuncture. So it is very important to be careful, and we should follow the SOP of the blood collection for the blood culture, so that we can avoid this contamination. And the culture positivity 3 or 4 out of 4, it indicates bacterial endocarditis. Now, Streptococcus pneumoniae, if we get from blood, CSF, blood owned, they are pathogenic. But if we get from sputum, it may be pathogenic, but usually they are colonizer in sputum. So during diagnosis, we should be careful whether it is colonizer or pathogenic. The preferred therapy, the multi-drug resistant Streptococcus pneumoniae, respiratory quinolones. These are the preferred drugs. And penicillin resistant streptopneumonia is still sensitive to full dose or high dose of beta lactams. If possible, we should avoid macrolides, as more than 30% are resistant. Now, Neisseria meningitidis, gram negative. And it is pathogenic when we get this organism in CSF blood. In sputum, it may be colonizer, also in urine, wound. But
what is ABM? Please explain what is ABM.
Acute bacterial meningitis. Acute bacterial meningitis caused by Neisseria meningitidis. Hello?
Yes, please.
Okay,
carry on.
So acute bacterial meningitis caused by Neisseria meningitidis. So it is pathogenic. There is no question of any colonizer or contaminant. And the preferred therapy is amoxicillin, ampicillin, any third generation cephalosporin like cefotaxime, ceftriaxone. Alternative therapy, chloramphenicol, vancomycin, cefepime, meropenem. This slide taken from Davidson in Principles and Practice of Medicine, latest edition. They are giving the guideline, the treatment of bacterial meningitis of unknown cause. Say the clinician dealing a patient of meningitis, he or she suspecting the patient is suffering from bacterial meningitis, and he advised to get the CSF for culture sensitivity. After sending culture sensitivity, the physician must start antibiotics. If he suppose he want to diagnose that it may be, he suspected it may be.
তোমার ইচ্ছা, আমি 10টায় খাবো।
ম্যাডাম একটু মিউট করেন ম্যাডাম।
ও সরি
ম্যাডাম প্লিজ, থ্যাংক ইউ ম্যাডাম।
আমি আজকে এই কাজটা করলাম।
না ম্যাডাম কোনো অসুবিধা নাই, প্লিজ রিপন কন্টিনিউ করো। থ্যাংক ইউ।
Okay, thank you. So if the physician suppose that it may be bacterial meningitis, but still the culture sensitivity is not in the hand of physician, then it may be due to any bacteria. So in that case, these are the guidelines for the adult type of adult age less than 60 years, cefotaxime, ceftriaxone. If the penicillin resistant pneumococcal infection, in that case, vancomycin, rifampicin, add to the above mentioned antibiotics. And these are the guidelines. But in the bottom of the guideline, you can see that antibiotic recommendations depend on local epidemiology of organisms and antibiotic resistance. Local guidance should always be sought. In all the empirical therapy written in the clinical books or different documents, they always give the notaben that these recommendation must be guided by the local antibiogram. So this guideline also from Davidson Medicine, the chemotherapy or antibiotic of bacterial meningitis. If it is Neisseria meningitis, the preferred therapy is cefotaxime, ceftriaxone, and alternate therapy benzyl penicillin, chloramphenicals. These are the other bacteria. Actually, these are the empirical therapy. Of course, it should be local guidance should always be sought. These two lines are always mentioned at the end of the guideline. These two things should be remembered. In acute bacterial meningitis by Neisseria meningitis, we should not decrease meningeal dose of beta-lactam as patient improves. Why? Because CSF penetration decreases as inflammation decreases. So during the whole process of the disease, the dose of beta-lactam should be same. And chloramphenicol is excellent choice for penicillin allergic patient. Now, Neisseria gonorrhoeae, they are pathogenic in urogenital system, as in urine and urethral discharge and pathogen. And they causes the urethritis and gonococcal proctitis and other complications, but usually they are not pathogenic when we get CSF from CSF, sputum, owned infections. The preferred therapy is the ceftriaxone, any quinolones, but we can also give the alternative therapy, that penicillin, amoxicillin, doxycycline, like that. This guideline taken from the Davidson Medicine, it showed the uncomplicated anogenital the gonorrhea, the single dose ceftriaxone is the preferred, or we can give the ciprofloxacin single dose. The pregnant lady, the ceftriaxone can be given, and disseminated gonorrhea, the ceftriaxone or cefotaxime, and switch to oral alternative according to sensitivity after 48 hours. So empirical therapy switch to the definitive therapy according to culture sensitivity report. Cause of culture negative right-sided endocarditis may be cultured from synovial fluid. Actually, these are the disseminated gonococcal infection. So it can be cultured from the synovial fluid or blood. And this strain from these are the study from the outside. There, the quinolone resistance also increasing. In that case, cefixime, ceftriaxone can be used, and the partner should be also treated if one person has the infection with gonorrhea. Now, gram-negative bacilli, Escherichia coli, they are in the gut, they are non-pathogenic, but they are pathogenic when isolated from CSF, blood, urine, bone, and sometimes from sputum. Here, preferred therapy is cephalosporin, second, third generation, any quinolones, ceftriaxones, nitrofurantoin. Alternatively, estrionam, gentamicin, cotrimoxazole can be used. These guidelines taken from Davidson Medicine here shown the antibiotic regimen for UTI in adults. Here, there is nothing mentioned regarding any bacteria. But if physicians suspect that it may be the UTI in the form of cystitis, their choice is trimethoprim, nitrofurantoin, then second choice. If they suspect that the UTI in the form of pyelonephritis, sorry, first choice is cephalexin, ciprofloxacin. If it is epididymoorchitis in young men, they give the ciprofloxacin in both young and older men. In acute prostatitis, first choice ciprofloxacin, and these are the second choice. You can see the duration is some are 3 days, some are 7 days, and 14 days, but there are some prophylactic dose also. But these are the empirical therapy, and after getting the culture sensitivity report of urine, they can switch to the definitive, the therapy, the which antibiotic is susceptible to, the organism is susceptible to the antibiotic, and they can choose the definitive therapy. Actually, these are the, I think, discussed. Now, Enterococcus faecium. It is actually the non-pathogenic if we get from CSF, except ventriculoperitoneal shunt. Also, it may be the skin contaminant if we are not careful regarding blood collection. Also, they are colonizer from sputum, urine, bone. Actually, these are the colonizers, but it may be pathogenic in urine or blood, in CSF in case of BP shunt. So in that case, we should consider the different factors of the patient. In that case, the preferred therapy is linezolide, quinupristin, dalfopristin combination, doxycycline, minocycline, and other drugs. If it is the subacute bacterial endocarditis, other infection other than the subacute bacterial endocarditis. If it is subacute bacterial endocarditis, then linezolide same, quinupristin, dalfopristin same, dalfopristin. Here, dalfopristin is the third choice. This guideline from, again, from Davidson Medicine, the antibiotic of common causative organism in infective endocarditis, it depends on the penicillin sensitivity, susceptibility, where MIC is less or 0.125, then more than 0.125, less than 0.5, MIC more than 0.5. Saying that in these less than 0.125 penicillin, benzyl penicillin IV. If it is mid portion, it is headed by gentamicin. If it is more than 0.5, then actually it may be resistant to the penicillin. So in that case, vancomycin should be given with gentamicin. If it is enterococci, the suspect enterococci, in that case, the amoxicillin, if it MIC less, so amoxicillin and gentamicin, and amoxicillin MIC less than 4, and gentamicin MIC less than 128. So less MIC, amoxicillin and gentamicin. If it is more MIC, then go to vancomycin and gentamicin. So these are Staphylococcus, the native valves, prosthetic valves are different types of antibiotics and different types of the duration of the antibiotic, either native or it is prosthetic valves. But we should remember that these are the proposed preferred therapy, and we should choose our antibiotic according to our local epidemiology of organism and the local antibiogram. Enterococcus faecium, fecal carries it intermittent, but it may be prolonged. Usually they are colonizer, but sometimes they may be the pathogenic. Nitrofurantoin is preferred for vancomycin resistant enterococci producing lower UTI. Enterococcus fecalis, usually they are non-pathogenic skin contaminant, but they may be pathogenic in urine, blood, in CSF when there is the if there is a VP shunt due to immunocompromised or any biofilm production or other factors, it may be pathogenic. So if they causes the bacterial endocarditis, then therapy, gentamicin, amoxicillin combination, meropenem, like this. If they causes infection other than this bacterial endocarditis, then the preferred therapy, sorry, ampicillin, amoxicillin, meropenem, piperacillin, tazobactam, linezolide, tigecycline, daptomycin, like this. We should remember that the Enterococci fecalis, they are sensitive to ampicillin, not penicillin. And cefoperazone is the only cephalosporin that can be used in this Enterococci fecalis. Now, Acinetobacter. Acinetobacter, mostly they are the colonizers, but they may be pathogenic in CSF sample, in blood. They are always pathogenic. Dear participants, I want to take pause my presentation for 1 minute. Sorry. Sorry for the interruption. Acinetobacter species, these are the pathogenic when it is found from the blood and urine, but also from the CSF. And the minocycline, carbapenem, ampicillin, sulbactam combination, tigecycline, colistin, these are the preferred therapy. These are the alternative therapy, the cephalosporin first, second, third generation, except ceftazidime, cefepime, estunam. These can be alternative therapy. As we we know the ascendant vector is mostly colonizer, but it can be pathogenic in some conditions, and mostly in the hospital setting. We know the ventilator associated pneumonia or catheter induced related UTI. So in that case, the colistin, polymyxin B, tigecycline, minocycline usually effective. Now Klebsiella pneumoniae. Klebsiella pneumoniae mostly pathogenic when we diagnosed the bacteria from CSF, blood, sputum, bone, also from urine, but in some samples, it may be colonizer like bone, sputum, and tigecycline carbapenem is preferred therapy. And alternative therapy is cephalosporin, quinolone, aztreonam, and cefepime. This guideline also taken from Davidson medicine, the antibiotic treatment for community acquired pneumonia. Here, the antibiotic guideline, it is mentioned according to the curve score. We know the confusion, uremia, respiratory rate, blood pressure. The curve score 65, age 65. A score, actually the clinical score. So it is. I'm not going to details. If the score is 0 to 1, that means 0 to 5 maximum. So 0 means less severe, 5 means more severe. So curve score 0 to 1 means low severe, score 2 moderately severe, and score 3 to 5 is severe pneumonia. Here it is community acquired pneumonia. So in that case, they propose the antibiotic amoxicillin. If the patient is allergic to penicillin, then preferred therapy doxycycline. If it is moderately severe, amoxicillin or benzathine penicillin plus clarithromycin. If it is severe, in that case, coamoxiclav or ceftriaxone or ceftriaxone plus clarithromycin or benzathine penicillin. If Legionella is strongly suspected, then physician consider to add levofloxacin. So actually, these are the proposed empirical therapy. It should be guided by local antibiogram. So this guideline showing the antibiotic for adult 18 or more with hospital-acquired pneumonia. They propose first choice of antibiotic for non-severe symptoms or signs, not higher risk of resistance, coamoxiclav. Alternative oral antibiotics for these non-severe symptoms or signs, that is doxycycline or cephalexin, cotrimoxazole, levofloxacin. First choice IV antibiotics if severe symptoms or signs or at higher risk of resistance. In that case, options are piperacillin with tazobactam, ceftazidime, ceftriaxone, cefuroxime, meropenem, ceftazidime with avibactam, levofloxacin. Antibiotic to be added if suspected or confirmed MRSA infection. That options are vancomycin, teicoplanin, or linezolid. Klebsiella pneumoniae, cotrimoxazole may be ineffective in systemic infection, and Klebsiella is usually susceptible to carbapenem. And carbapenem resistant enterococci are susceptible to tigecycline, colistin, polymyxin B, like this. And NDM1 metal beta lactamases producer are carbapenem resistant and usually susceptible to colistin and tigecycline. Now for Pseudomonas aeruginosa. For Pseudomonas aeruginosa, they are environmental contaminant, you know. Mostly they are non-pathogenic, but they may be pathogenic in blood, in sputum, in urine, in that case, we must consider the different factors of the patient, including immune status, age, like this. The preferred therapy is ceftazidime, meropenem, cefepime, and in combination therapy, meropenem plus either cefepime or amikacin. The doripenem, amikacin, estunam are the alternative therapy. So colonization is common, infection uncommon. So avoid treating pseudomonas in evaluated patient unless tracheobronchitis. So if you consider that the patient is suffering from ventilator-associated pneumonia or any infection due to pseudomonas, if there is tracheobronchitis, so any features of tracheobronchitis, in that case, we should start the antibiotic for Pseudomonas aeruginosa. For serious systemic infection, double therapy may be needed, and all double drug therapy are equally effective. If multi-drug resistant Pseudomonas aeruginosa is meropenem resistant, we should treat with colistin, colimixin B, doripenem, or ceftazidime or avibactam combination. Now, something about Burkholderia capacia, the bacteria from the similar member of family Pseudomonas. Burkholderia capacia, mostly they are either colonizer or non-pathogenic, but sometimes they may be pathogenic. It accidentally goes to the blood from IV line, or it may go to the blood by renal system if the patient is suffering from the UTI. In that case, they can be pathogenic, and in that case, the preferred therapy will be trimethoprim sulfamethoxazole combination, minocycline, meropenem. Alternatively, we can use respiratory quinolones, chloramphenicol, cefepime. And we all know that these Burkholderia capacia, that are the opportunistic pathogens in the patient with cystic fibrosis and bronchiectasis. Now, Burkholderia pseudomeli, we know the melioidosis, and actually this melioidosis, the epidemiologically we are little known about the melioidosis, but there are different studies going on in our country, in our higher centers, including BARM, BSMMU, and other some centers. There are more prevalence of melioidosis, and in October in Dhaka, International Melioidosis Conference is going to be held. So we should more focused also on this melioidosis. Burkholderia pseudomeli causes melioidosis. Actually, this bacteria also the environmental organism. They are not usually pathogenic to us, but they can be pathogenic if it is accidentally entered into the blood. Also, the patient suffering from any cavitary pneumonia, in that case, it may be pathogenic. And preferred therapy is imipenem, meropenem, ceftazidime, doxycycline. Alternative therapy, trimethoprim sulfamethoxazole combination, amoxicillin, clavulanic acid combination. So the prolonged therapy may be needed to prevent relapse for the more than 3 months. And here oxidase test positive, they are resistant to penicillin, aminoglycoside, and colistin. So the Burkholderia pseudomeli, when the colony in the McConkey agar, oxidase positive, but they are resistant to penicillin, aminoglycosides, and also colistin, we should suspect as Burkholderia pseudomeli. Now, Campylobacter jejuni, enteric bacteria, gram-negative bacteria, they also non-pathogenic, but they can be pathogenic in sometimes opportunistic pathogenic. They can cause the bloody diarrhea and other some complications, and they can enter into the blood from GI source. They also can be pathogenic. Preferred therapy, erythromycin, doxycycline, quinolones. azithromycin and clarithromycins are alternative therapy. And it requires a special media, everything known to you. Commonest cause of antibacterial diarrhea resistant to trimethoprim and sulfamethoxazole. Now, Enterobacter. Enterobacter mostly they are skin contaminant in CSF, in blood samples, and their colonizer in urine owned, but they can be pathogenic if any neurosurgery operation or any procedure, they accidentally enter into the meninges, and from IV line or UTI, they can go to the blood, then that can be pathogenic. In urine, usually they're colonizer, but any urological instrumentation like cystoscopy or other instrumentation, in that case, it can be a pathogenic. And immunocompromised patient, it can be pathogenic in wound infection. And preferred therapy is any carbapenem and quinolone, aztreonam, penicillin, tazobactam combinations, CPFIM are the alternative therapy. They are common colonizers of respiratory and urinary tract. It is already mentioned that Enterobacter carbapenem resistant Enterobacter is usually susceptible to trigacycline, colistin, polymyxin, ceftazidime, avibactam, fosfomycin. Now, Haemophilus influenzae. Haemophilus influenzae, they are pathogenic when isolated from CSF, blood, but mostly they are non-pathogenic in wound, stool, urine, but sometimes they may be pathogenic and they can cause community acquired pneumonia. Here, any second, third generation cephalosporin, any quinolones, doxycycline are preferred therapy. Alternative therapy, chloramphenicol, trimethoprim, sulfamethoxazole combination, azithromycin, and they are alternative therapy. So they are really a cause of culture negative bacterial endocarditis. So we should be careful during culture of blood to diagnosis of bacterial endocarditis. Something about the Serratia marcescens. They can be pathogenic in CSF, blood, but mostly they are colonizer in sputum, urine, stool, and wound. And here also it is pathogenic by different conditions mentioned in the Haemophilus influenzae, like neurosurgical procedure in CSF, urinary source or IV source, IV line to the blood stream, pathogenic. Urological instrumentation causes the pathogenic to urine or renal tract, UTI, and ON, that is the pathogenic in rare condition, in immunocompromised condition. Any third generation cephalosporin, quinolone, CPFIM are preferred therapy. Any carbapenem, gentamicin, aztreonam are alternative therapy. You can see that the gentamicin has highest anti-serratia activity. So gentamicin is more susceptible to the serratial, anti-serratial activity. Helicobacter pylori, mostly they are non-pathogenic, but they are associated with different types of ulcer at duodenum, stomach, and other site of a small intestine. And they also involve in the development of gastric cancer and maltoma, this type of the tumor. And preferred therapy, we know the eradication therapy, Helicobacter pylori eradication therapy, PPI plus 2 of antibiotic, clarithromycin, amoxicillin, metronidazole. The physicians are prescribing the eradication therapy just by guess. But in recent studies, it is shown that the clarithromycin, amoxicillin are getting more and more resistant. So I think the time is coming where we should prescribe the Helicobacter pylori eradication therapy after culture sensitivity of Helicobacter pylori. Otherwise, the blindly use of this clarithromycin amoxicillin combination with the PPI, it could be failed to eradicate Helicobacter pylori because we don't know whether the clarithromycin, amoxicillin, or metronidazole are resistant or susceptible. So I think the importance of the Helicobacter pylori culture sensitivity will be more and more importance to eradicate this bacteria. Something about Salmonella typhi. Salmonella typhi, actually they are non-pathogenic in CSF sputum own, but it is pathogenic when it is entered into the blood from GI source. And in case of enteric fever, it is pathogenic in renal tract. In case of enteric fever, from the blood, it goes to the renal tract. In that case, it can be pathogenic. And preferred therapy, any quinolones, third generation cephalosporin like ceftriaxone, ceftriaxone, azithromycin. But in our country, the ciprofloxacin or other quinolones are getting more and more resistant. Alternative therapy, cotrimoxazole. If drug therapy failed to eliminate carrier state, look for hepatic or bladder stone for persistent focus. And this carrier state best eliminated by ciprofloxacin or other quinolones for 4 weeks. That means double duration. For enteric fever, dose is for 2 weeks. For elimination of the carrier state, the duration is double, 4 weeks. Another bacteria, Stenotrophomonas maltophilia. This Stenotrophomonas maltophilia, they cause lots of infection in pneumonia, acute exacerbation of COPD, bacteremia, septicemia, soft tissue, skin soft tissue infection, cellulitis, osteomyelitis, catheter-related bacteremia, septicemia, mostly the hospital-acquired infections. And actually, they are the skin contaminant in blood, but they are colonizer in the CSF, sputum, own, but they can be pathogenic when there is neurosurgical procedure in CSF from IV line, they accidentally enter into the blood. By urological instrumentation, they enter into the renal tract and they cause UTI. And immunocompromised patients, it can be responsible for wound infection. The cotrimoxazole, tigecycline, minocycline, ceftazidime, avibactam combinations, these are the preferred therapy. Doxycycline, respiratory quinolones are the alternative therapy. So they are a common colonizer of urine already mentioned. They are resistant to carbapenem and aminoglycoside, but they are susceptible to chloramphenicol, rifampicin, colistin, polymyxin B. They are potential pulmonary pathogen in bronchiectasis and cystic fibrosis. Now, Clostridium difficile. Actually, the facility to identify these anaerobic bacteria is very, very limited in our country, but we should improve our facility so that we can detect the anaerobic bacteria like Clostridium difficile, bacteroids like this. And these Clostridium difficiles are usually non-pathogenic in different sites, but they can be pathogenic in blood if they enter into the blood from any GI source. And in that case, in diarrhea, the preferred therapy is vancomycin. And this Clostridium difficile, we know, they cause pseudomembranous colitis. And in that type of the colitis, metronidazole, tigecycline is the drug of choice. In diarrhea, the vancomycin, nitazoxanide, fidaxomicin is the drug of choice or preferred therapy. Alternatively, in diarrhea, we can use metronidazole. And in colitis, we can use nitazoxanide. I think it is already discussed. Now, Bacteroides fragilis, mostly they are non-pathogenic, but they can be pathogenic and they causes the meningitis. Actually, in the Strongyloides stercoralis hyperinfection, in that case, the bacteroids can be causes of the bacteroid meningitis. In any pelvic sores, they can enter into the blood, and they can cause bacteremia and septicemia. And preferred therapy tigecycline, piperacillin, tazobactam combination, carbapenem. And alternative therapy is ampicillin, salodectam combination, clindamycin, metronidazole plus ceftriaxone, or levofloxacin combination. So usually part of polymicrobial lower intra-abdominal or pelvic infections. So last one is the brucella. We know the brucella also very important bacteria and most important cause of pyrexia of unknown origin. Usually we are missing the diagnosis of brucella, so we should also be focused on diagnosis of brucella. These treatment guidelines also from Davidson Principle and Practice of Medicine regarding the antibiotic empirical therapy of brucellosis. If the patient is adult with non-localized disease, preferred therapy doxycycline plus gentamicin or doxycycline rifampicin. If the lesion is the bone, osteomyelitis or others, then doxycycline plus rifampicin or ciprofloxacin plus rifampicin. If it is involvement in the central nervous system, neurobrucellosis, preferred antibiotic doxycycline plus rifampicin. If it is endocarditis, almost always needs surgical intervention plus doxycycline, rifampicin, and cotrimoxazole. Any pregnancy, if there is a brucellosis, so rifampicin and cotrimoxazole. So these are the references. Actually, most of the slides are taken from this book, Antibiotic Essentials.